In this segment, we're going to do a high velocity, low amplitude technique, again to the thoracic area. Again, I'll use the T7 as an example. In this case, we're going to have an extension dysfunction. Now, clinically, you'll find a little bit more frequently the extension dysfunctions being in that lower thoracic area as the posterior body's curve meets the lumbar and gets into that lordotic curve, and it tends to be the more posturally oriented, sort of typical, less traumatic type 2, let's say. Now in this case, again, we're going to say it's left-sided rotation, so we're going to cross the arms with the left arm on top of the lower to get the scapula again out of the way. Therefore, I will stand on the right since it's left rotation. As I said in the other segment, the rotational components in these flexion extensions aren't quite as dynamically treated directing the rotation as we did with the type 1, where we're actually on the segment with our thenar eminence and mobilizing through a rotational force. We're actually more tangentially related in these. Now, in the extension dysfunction, we're trying to meet a flexion barrier, so we have to move the upper of the two into flexion over the lower of the two. And this is what we're going to do. To do that, we're going to use a short-levered thrusting effect with our thenar eminence, pushing upwards on the upper of the two, moving that into flexion. But to do that, I have to set up a force vector that generates from the front of the patient's body directed to the lower of the two to move the lower of the two in the opposite direction. We count down the spinous processes, we find T7, again knowing that the transverse process is lateral and a step upwards. I have that spot located. Now in this case, since the physician's force is going to be generated to the lower of the two, my thenar eminence is going to stay on the upper of the two. So in this case, I have an extension dysfunction, and my force is going to be directed to the lower, but my thenar eminence has to be on the upper. Now, I'm going to ask the patient to lift up his head, make sure I have that contact. Now, since it's rotated to the left, side bent left, I'm going to take the side bending effect over and move it to the right barrier. I have my hand on the left side to help a little bit with that rotational component, and now the rest of the technique is going to be performed in direction of the extension flexion component. And since it's extended and I needed to make it move into flexion, my bottom or my thenar eminence hand is going to be pushing upwards on that segment, moving it into flexion as my anterior body weight falls to the lower of the two and I rock down towards my elbow. So I have him in position, ask the patient to take a deep breath, and as he lets out the deep breath, my body weight shrugs down to my elbow and thrusts below it with my thenar eminence pushing up. And I'll do it one more time. Position, take a deep breath, and let it go. Whereas in the flexion dysfunction where we had to extend it, my hand was on the lower of the two, I had the patient up, he took the deep breath, and as he let it out, I forced it above and took it into extension. So in class we're going to tell you a little mnemonic. Fuel. If it's flexion, your force, the physician's force is to the upper of the two segments, and if it's an extension dysfunction, the physician's force is directed to the lower of the two segments involved. And just remember that that's the push that you're putting into the system, not the thenar eminence. And if you know that the force is directed to the upper of the two, then you know that your thenar eminence has to be placed on the lower of the two, or towards that. And if it's force to the lower of the two, your thenar eminence will move to the upper of the two.